audience.
We are on YouTube now.
Muy buenas noches a todos, bienvenidos. En un momento iniciamos.
Estamos grabando ya.
Perfecto.
Si puedes, Mónica, en algún momento, igual tú y yo vemos lo del YouTube, si ves algo, si quieres poner algún mensaje o algo, yo también.
En YouTube sí,
Ahí
de
te
una vez ahorita
secundo.
lo pongo.
Ajá, te secundo.
Sí, no. Sí, ahorita.
Está el doctor Vilar, doctor García Lara. Doctor Vilar. Buenas noches.
Ya lo vi. Maestro, muy buenas noches, bienvenido.
Ya le mandé la invitación de que si quiere quitarse para que salude al doctor igual.
Sí, bueno, sí, es que bueno, están bloqueados ahorita los micrófonos para que no tengamos interferencia. Agradecemos también al doctor Héctor Ruiz de Argentina que está aquí con nosotros, de la Asociación Panamericana. Bienvenido, doctor, un gusto tenerlo con nosotros.
Ya está el doctor Vilar, doctor, si quiere dar un saludo. Ah, sí, creo que se le quitó el micrófono. Se lo quitó, doctor. Ahí está.
¿Sí me escuchan?
Sí,
doctor.
Sí, bueno, como usted, León Felipe sabe que la Trompa de Eustaquio fue una de mis obsesiones por muchos años. Y hicimos muchos trabajos y publicamos muchos trabajos. Y es un verdadero placer ver cómo se está progresando, pero todavía es mucho más lo que ignoramos que lo que sabemos, y sobre todo cómo encontrar soluciones a las disfunciones, ¿no? Claro, de lo que hacíamos hace 30, 40 años, se ha mejorado mucho con la endoscopía y todo lo que pues ustedes saben ya mejor que yo, pero sí me da mucho gusto poder escuchar. Yo al doctor Poe en alguna ocasión creo que estuve en un curso en San Francisco y él ya nos hablaba de la Trompa de Eustaquio. Eso hace ya como 10 años.
Excelente. Pues muchas gracias, maestro, por estar aquí con nosotros.
Debo silenciar, ¿verdad?
Sí, es tan amable en apagar su micrófono.
Gracias, doctor.
Bueno, pues estamos en tiempo y vamos a dar inicio a nuestra sesión. A nombre del Colegio Mexicano de Otología, Neurotología y Cirugía de Base de Cráneo, les damos a todos la más cordial bienvenida a nuestra sesión mensual, que como saben, este colegio tiene pocos años de haber sido fundado y poco a poco ha ido creciendo. Hemos iniciado con profesores internacionales y ahora tenemos una grata presencia de un líder a nivel mundial. Les vamos a pedir a todos, bueno, tienen por ya sistema de nosotros apagado su micrófono. Posteriormente, si alguien quiere usar la voz, lo vamos a poder hacer. Pero también en el chat pueden ir colocando sus comentarios o preguntas que contestaremos al final en vivo con el doctor. Tendremos la parte de preguntas y respuestas. Bien, pues quiero presentar y agradecer enormemente al doctor Denis Poe la presencia esta noche con nosotros. El doctor tiene amplia experiencia en otología y en neurotología. Tiene un currículum muy amplio. Me voy a permitir mencionar algunas cosas que considero son muy importantes de nuestro invitado esta noche. Él realizó estudios de química y de ingeniería de manera inicial en la Universidad de Syracuse, en Nueva York. Posteriormente, medicina, también en una universidad de Syracuse. Y después hizo un entrenamiento de cirugía general para después entrar propiamente a la residencia de otorrinolaringología en Chicago. Después un fellow en otología con el grupo de Nashville, en Tennessee. Y finalmente estuvo una estancia para hacer un doctorado en Finlandia, donde pues, fue que se apasionó mucho más por la parte de la trompa de Eustaquio. Como cirujano neurotólogo que trabaja en un hospital pediátrico, se dedica al manejo de los niños y algunos adultos en su práctica de referencia, tanto nacional como internacional, y se formó en ingeniería biomédica, por lo que gran parte de su trabajo ha implicado buscar soluciones tecnológicas a problemas en la otorrinolaringología, y con esto ha tenido una serie de colaboraciones con ingenieros de centros académicos como el MIT y también pues con otras industrias. Sus contribuciones en la otología iniciaron con el desarrollo de la cirugía endoscópica mínimamente invasiva del oído, y fue uno de los primeros en presentar el uso de estas técnicas en el inicio de los años 90. La investigación de la anatomía funcional y la fisiopatología de la trompa de Eustaquio lo ha llevado a crear nuevos métodos de diagnóstico y procedimientos quirúrgicos para su tratamiento. Durante su estancia de año y medio en Finlandia, amplió su trabajo en el estudio de la trompa de Eustaquio, refinando técnicas quirúrgicas y posteriormente iniciando con ensayos clínicos. Ahí es donde obtuvo un doctorado precisamente en el campo de la fisiopatología de la trompa de Eustaquio. A su regreso a Estados Unidos, participó en un grupo para el diseño de los dispositivos de balón para la dilatación de esta estructura. Ha sido profesor en diversos lugares, en la Universidad de Tufts en Boston, posteriormente en el Departamento de Otorrinolaringología del Hospital Infantil de Boston y desde luego en la Escuela de Medicina de Harvard en la misma ciudad. Es profesor visitante de la Facultad de Medicina en Tampere, en la misma Finlandia, donde realizó sus estudios. Miembro de diversas asociaciones como la Academia Americana de Otorrino, la Sociedad Americana de Neurotología, el Colegio Americano de Cirujanos, la Sociedad Triológica de Estados Unidos, la Academia Europea de Otología y Neurotología, y es fundador y organizador del grupo de estudio de la trompa de Eustaquio, que habitualmente se reúne durante el Congreso Anual de la Academia Americana de Otorrino. Diversos cargos como presidente de la Sociedad Otorrinolaringológica de Nueva Inglaterra, ha participado en diversos comités como asesor, comités científicos en otología, y es miembro correspondiente de la Sociedad Alemana de Otorrinolaringología. También diversos premios y honores ha recibido, como profesor del año, excelencia en la enseñanza en la Escuela de Medicina de Harvard y en el Hospital Infantil de Boston, excelencia en investigación clínica de la Sociedad Triológica y diversos premios como al servicio distinguido por la Academia Americana de Otorrinolaringología. Tiene más de 150 trabajos originales publicados. Sus temas principales han sido la cirugía endoscópica del oído y del hueso temporal, como decíamos, como uno de los primeros en desarrollar técnicas endoscópicas mínimamente invasivas para la cirugía del oído y la base del cráneo. Desde luego en la fisiopatología de la trompa de Eustaquio, buscando nuevos métodos diagnósticos y terapéuticos clínicos y quirúrgicos, y su investigación ha revelado una serie de nuevos hallazgos clínicos que han modificado las teorías previas de la función de la trompa de Eustaquio y su papel en la otitis media. Con su grupo de colegas de Finlandia publicó una escala de calificación recientemente validada para la inflamación en la región de la trompa de Eustaquio. También métodos diagnósticos para disfunción de la trompa, y con su grupo han diseñado un sonotubómetro que se sincroniza con el endoscopio para utilizar la información de manera combinada. También en otros aspectos de la otología, en el síndrome de dehiscencia del canal semicircular superior, ellos encontraron manifestaciones auditivas que no habían sido reportadas previamente y comenzaron a estudiar también estas condiciones a detalle. Su grupo fue el primero en describir esta entidad en niños y también, más recientemente, la dehiscencia del canal semicircular posterior. Y otro aspecto que también ha trabajado es en la evaluación de las fístulas perilinfáticas, utilizando técnicas endoscópicas del oído para investigar el diagnóstico de esta patología. Esto es solo una breve parte del gran currículum, pero además de toda esta parte académica, la calidad docente, profesional y humana del Dr. Po nos han permitido que acepte la invitación para estar esta noche con nosotros. Y sin más, vamos a iniciar con la presentación de su tema, que se llama Evaluación de la disfunción de la trompa de Eustaquio. Iniciamos, por favor.
Doctor, no sé si quiera dar instrucciones a los participantes de cómo poner su traducción, y nada más si el doctor Po quisiera dar algunas palabras antes de empezar.
Sí, bueno, la plática está en inglés, o será dada en inglés. En la porción inferior de su barra de menú está el apartado de traducción. Ahí ustedes pueden seleccionar si quieren tenerlo en inglés, en el lenguaje original, o si quieren ponerlo en español. Ahí lo seleccionan, donde tendremos la traducción simultánea. Durante la plática, si quieren estar cambiando entre uno y otro, bueno, lo pudieran hacer si es que en algún momento quieren escucharlo en el otro idioma, y deben colocarse ahí en esa parte para no tener ningún problema. Doctor Po, si quisiera comentar algo antes de iniciar la plática.
Dr. Leon Felipe and Dr. Erica, Dr. Monica, and others, thank you so very much for this privilege to be with you this evening. It's wonderful that after a long day in a work week, so many of you are willing to take time out this evening to listen to a talk. So I really appreciate your interest in this field, and it's my honor to be able to speak with you this evening. So thank you very much. We pre-recorded the lecture because so often things happen, internets go bad. So please enjoy the lecture. I'm going to stay with you the whole time. I'll be ready for your questions when we're done. Thank you very much.
Sí, el doctor está contestando.
Muchas gracias, doctor Po. Como lo menciona, nos pidió que la plática estuviera grabada para evitar cualquier situación de problemas de internet, pero él está en vivo y estará para las preguntas. Insisto, pueden colocar en el chat, o si tienen alguna duda de cómo manejar la traducción, también lo pueden hacer en el chat. Iniciamos entonces, por favor, doctora Ced.
Empezamos.
Buenas tardes a todos y muchas gracias por esta oportunidad de hablar con ustedes esta tarde. Dr. Garcia Lara, ladies and gentlemen, thank you so much for this privilege to be speaking with you this evening. I'm going to talk about evaluation of eustachian tube function. I'm Dennis Poe. I'm in the Department of Otolaryngology at Boston Children's Hospital, Harvard Medical School, and it is a real pleasure to be with you this evening. So now that we have surgery for the eustachian tube disorders, I'm commonly asked, who are the right patients? What are the indications? How do we evaluate the eustachian tube? And that's what we're going to talk about this evening. So my disclosure, I am a consultant for the Acclarent Corporation, so they can pay me for my time and expenses. I have no equity interest in the company, and I have no royalties from their products. So we think about the eustachian tube very differently now. It's a functional valve that aerates a sinus. The middle ear and masseter function as a sinus, and the eustachian tube is like an ostium, but it's very different because it's a long, curved, and dynamic functional valve. This is a human cadaver eustachian tube in longitudinal section. This is the nasopharyngeal orifice at the 0 marker. It tapers along the cartilaginous portion, getting smallest at the isthmus, which is about 25 millimeters. And then the bony portion expands into the middle ear here. Now, as surgeons, we want to be aware that it is actually not a straight organ. It is curved quite a bit. You can see that in this patulous eustachian tube because of the air contrast with the valve being open. And notice that it curves more medially than you think before it curves laterally to the ear. But this is a patchless eustachian tube. If the torus were thicker and the valve were closed, that would make the curvature even greater. So we have to recognize that as surgeons. And also keep in mind as surgeons, the higher you get in the eustachian tube, when you leave the cartilaginous portion and you get into the bony portion, you're immediately adjacent to the internal carotid artery. As you can see in this cadaver half head section, that's the inferior turbinate, and this is the floor of the nose. So we've learned that most of the pathology that affects eustachian tube disorders is in the cartilaginous portion, the functional valve. It's not at the narrowest part, the bony isthmus or the bony portion, in most cases. And we know this from extensive endoscopic work. So the way to view the valve is with an angled view, either a rigid endoscope, 30 or 45 degrees, or by flexing your fiber optic endoscope to get this view. So we have a right eustachian tube. This is the torus tubarius. This is the anterolateral wall. This is the anterior pillar. We want to see both walls, this anterolateral wall and the posteromedial wall. Where they meet, that comprises the valve. Now this bulge from the anterolateral wall has to be completely opened in the active open position. And that happens with the action of the levator muscle in the floor and the tensor veli palatini muscle in the anterolateral wall, flattening out this bulge. And that bulge is the bulk of the muscle, Ostman's fat, the mucosa, submucosa, and some of the lateral cartilaginous lamina that protrudes here. Now, examination of the valve of the eustachian tube is very similar to examining the vocal cords. Now here we see there's the epiglottis, but that's not your target, that's the vocal cords. Many people just look at the torus tubarius and say, well, that's the eustachian tube. That would be akin to looking at the epiglottis, and yet you're planning vocal cord surgery. You wouldn't do that. You need to see the vocal cords. In the eustachian tube, you don't need to see just the torus, you need to see the valve itself, both posteromedial and anterolateral walls. So keep that in mind. You wouldn't dream of operating on the vocal cords if all you saw was the epiglottis. And we shouldn't be doing that with the eustachian tube either. So how do you view the eustachian tube? We've been trained originally to do it with a 0-degree endoscope, fiber optic or rigid. And this is the view you get. This is the right side. There's the torus tubarius, adenoid, and there's the lumen. You can see some of the lumen in most patients. That's the anterior pillar. But with an angled view, now we truly see the valve, both walls, just like seeing both vocal cords. This is the torus, the posteromedial wall, the anterolateral wall. And we see where they meet. That's the valve. That's the view we need to see. Now, if you can get that with a 0-degree scope, which you sometimes can, that's adequate. But most of the time, we should be using an angled view. Now, the most common way that I look at the eustachian tube is with a fiber optic endoscope. So we have the endoscope inserted in the nose. I look at the nasal cavity, sinuses, the nasopharynx, and then we drop it down to look at the larynx for signs of reflux, hypopharynx and larynx. Then I back it up into the nasopharynx, and I'll turn the scope 90 degrees to look at the eustachian tubes. Once it's positioned, we have the patients vocalizing ka, ka, ka to move the levator and move the torus tubarius. And then I'll have them swallow to produce a normal opening of the valve, and then a series of yawns or vocalizing ah for maximal dilation of the valve. This is what that looks like. So we have a left side, there's the inferior turbinate, floor of the nasal cavity. This is the left eustachian tube, adenoid. Here's the vomer. Now, I'm going to rotate the scope 90 degrees, pass it beyond the vomer. Now we're looking across the vomer to the right eustachian tube. Now, I don't like looking sideways like this, so we're turning the endoscope camera to bring it back to an upright view. And now you've got just as good a view as you do with a rigid 45-degree endoscope. And then I have the patients do those maneuvers. So that's the most common way that we're doing this. This is a 0-degree view of the left side in a normal patient. That's the torus. Now with a 45-degree, we can see the valve. So there's the torus. This is the anterolateral wall. And so we'll look at some swallows here in slow motion. The first thing that happens is the palate elevates as the action of the levator brings it up. And it pulls, it rotates the torus medially to hold it open like a scaffold against which the tensor is going to fire. So this is the levator, medialization of the torus. And now watch the tensor fire. The valve is now open. And then the levator muscle and the tensor muscles are relaxing. That's the adenoid there medially. So here it is in a cadaver dissection. There's the levator in the floor, the tensor in the anterolateral wall. So a normal swallow will produce contraction of the levator first, and then the tensor opens the valve second. It's a 1-2 effect, levator, tensor. And that's what we're going to be looking at critically as we evaluate eustachian tubes. So here in detail, with a 45-degree scope is a left side. Now here we see robust inflammation. The patient just said ka, ka, ka. That's a swallow. And then watch as they do a yawn. There's a partial opening of the valve with the yawn there. Lots of edema, cobblestoning, very inflamed eustachian tube. Opens very poorly with a swallow. Here it is in slow motion. Watch the levator comes up. The torus actually didn't get medialized. It got thrusted anteriorly and is partially compromising the opening. We're going to look at a lot more similar examples, but this is an example of how we're going to approach this. So let's look at that fiber optic exam again. We've just left the larynx. Now I'm turning the endoscope 45 degrees. So I'm going to look now at the right eustachian tube in this patient. This person happens to be patulous. We're going to turn the camera again, so I bring the view upright. So we have a right torus tubarius. This is a bulge of the lateral cartilaginous lamina. The medial cartilaginous lamina is the skeleton of the torus. The patient's saying ka, ka, ka. We'll now do a swallow and a yawn for a maximal dilatory effort. Now we'll go ahead and look at the other side. This is the adenoid. This is the left side. There's the torus. Now there's some mucus in the way. So I'm going to do everything I can to try to get past that mucus. Have the patient sniff, blow their nose. In this case, I could pass the endoscope beyond it. Ka, ka, ka. Seeing how the levator works. A swallow. So there was the levator and the tensor. There's a yawn for a maximal dilatory effort. And we see how the valve never closes here. This is a patulous eustachian tube. So that's how we're going to critically do this examination. We'll look at a number of examples. Now here's some pathology. This is allergic rhinitis and a chronic middle ear effusion. Lots of inflammation, thick torus tubarius. This is the right side. Now look at the adenoid. It's only barely touching the torus. But when she swallows, that thick torus is being trapped. This is the lumen. It was closed by that anterior thrusting of the torus when the patient was swallowing. So even though the adenoid doesn't look like it's compromising the torus very much, during swallowing, when the pharyngeal constrictors come in, it compressed the torus between the adenoid, the lateral pharyngeal wall, anterior thrusting, closing the lumen. So here that is again. This is very common in pediatrics when you have adenoid hypertrophy. So there's some anterior thrusting with a swallow, and when we watch that in slow motion, you see it's very prominent. It closes the lumen of the valve at the very time it's supposed to be opening. Extremely common in pediatrics. And so removal of the adenoid, especially that lateral portion that's likely to be in contact, can be very effective. Now, this is allergic rhinitis, and this patient has a lot of inflammation here at the orifice, but there's atrophy in the lumen. Bulbous edema, thick inflammation at the orifice, but this yellow, that's Austin's fat being seen through atrophic mucosa. Now this paradox of inflammation in the nasopharynx and at the orifice of the eustachian tube, but patchy atrophy in the lumen, that commonly happens with allergic rhinitis. We know that allergic disease can cause patches of atrophy, burned out mucosa throughout the nose, sinuses, nasopharynx, and apparently it happens in the eustachian tube as well. Now, if that happens sufficiently that it compromises the valve and it cannot close adequately, you can get a patchless eustachian tube, even though you've got inflammation elsewhere in the orifice of the eustachian tube, nose, or sinuses. So you have to watch for that paradox. Now let's look at adenoid volume. This is a large adenoid mass, a right middle ear effusion, thick torus, lots of inflammation. This eustachian tube never opens, so the patient has chronic effusion. Now let's look at that in slow motion. So a right eustachian tube. Here's the swallow with the levator. Now the tensor is going to be firing, but we have that severe anterior thrusting of the torus tubarius, trapped between the large adenoid and the pharyngeal wall. Now contrast that to this adenoid, which is just as big, if not larger, in volume. There's the torus, also a right side. There's the lumen of the eustachian tube. Enormous volume of adenoid. That's the opposite torus. So watch what happens when this person swallows. It turns out there's a hollowed out portion here in the lateral adenoid. So we're not seeing any compromise of opening of the valve. The geometry of this adenoid is accommodating the torus. So it never develops any of that anterior thrusting or compromise of the opening, even though it's the same or more volume of hypertrophy. So it's not about the volume or hypertrophy. It's about how does it compromise the torus and the opening of the valve. So the only way you're going to know that is with this dynamic examination. Swallows for normal exams, normal opening, yawns, and vocalizing ah for maximal dilatory efforts. Then you'll see this kind of pathology. All right. We think of eustachian tube dysfunction now as a spectrum. At its worst, when it's obstructed completely, you have middle ear effusion. The obstruction can become increasingly less, and then eventually you can get a defect in the valve and become patchless. So when it's completely blocked, as you have here, these are all left ears with their corresponding eustachian tubes. So here we have an occluded eustachian tube. There's lots of mucus, lots of inflammation. It never opens, and you have a middle ear effusion. This one has lesser degree of inflammation. The eustachian tube opens sometimes. Some air gets through. So we have negative pressure in the middle ear, retraction, but there's no effusion. Some air is getting through sometimes. This patient has inflammation just limited to this redundant band of mucosa on the floor. And it only interferes with eustachian tube function when this person flies, when they're baro challenged. So in your office, they have a normal examination, normal tympanogram, lesser inflammation. Now, if you have a defect in the valve, perhaps from chronic allergic rhinitis causing patchy atrophy in the valve, you can get a patchless eustachian tube. And this patient has excursions of the tympanic membrane when they breathe through their nose. Now, these allergic patients in particular, when their disease is active, they can become obstructed, even to the point of effusion. But when their disease is more quiescent or they've been over-medicated, they can develop a patchless defect once again. And the patient's going to confuse you by only saying that they have fullness and pressure in their ear. They don't necessarily tell you about autophony of their voice and breathing sounds. So they can fool you just always saying, I have a blocked ear, even though they may be going back and forth on this spectrum. So we have to differentiate that. We have a rating scale for mucosal inflammation and the ability to open the eustachian tube. It ranges from normal to a mild compromise, mild inflammation, moderate compromise, moderate inflammation, and unable to open at all, severe inflammation. So this is a validated rating scale that we use. And the more inflammation they have, the more I'm likely to use a full 2 minutes duration when we do a balloon dilation. If they have lesser inflammation or even just barrow challenge, I don't want to do a full dilation. I might cause them to be patchless. So we use this evaluation and rating to determine how long are we going to inflate the balloon if we're going to do a balloon dilation. So to assess for obstructive eustachian tube dysfunction, it's a multifocal approach. Starts with the history. They usually are barrow challenged. They may have had otitis media. They have difficulty or they're unable to do a modified Valsalva. So I try to teach patients not to do a conventional Valsalva, nose and mouth closed and blowing hard. We've seen patients actually destroy their inner ear function with overpressurization when they suddenly pass to their middle ear and injure their inner ear. Much safer and much more effective is how the scuba divers do it. Nose and mouth closed, gently blowing, never hard, but simultaneously swallowing while they generate that positive intranasal pressure. Now you're using the muscles to open the valve. Now, most patients with obstructive eustachian tube dysfunction are not able to do that, or they find it difficult. If they can do that easily, you're already wanting to think about another diagnosis. Ask about autophony. If they're obstructed, that should be absent, rare. They shouldn't be hearing their voice and breathing sounds loudly echoing in their ear. The otoscopy combined with insufflation shows you whether there's negative pressure, retraction, fusion. Now, again, it could be normal if they only have barrow challenge. You can confirm your results from the otoscopy with the audiogram. If they're obstructed, they might have a conductive hearing loss. The tympanogram will show you whether they have negative pressure, type B or C tympanogram. Again, if they're only barrow challenged, only having trouble in flights, scuba, they may be normal at your office visit. So how do you really tell? Ultimately, the endoscopy, that dynamic exam, especially during swallows and yawns, 30 or 45 degree endoscope. And this assessment, this is my checklist for looking at the different aspects of the endoscopy. I look for how much mucus there is, edema, erythema, signs of inflammation, lymphoid hyperplasia, cobblestoning. Those are lymphoid follicles, adenoid-like tissue going down into the eustachian tube. The degree of tubal tonsil tissue. Is there anterior thrusting of the torus tubarius? So I call this and then finally, it's the opening of the valve. How well does it open? This one's not going to open. That's a MELO assessment. That's my checklist for the endoscopy. Now, one of the surest ways to tell obstructive eustachian tube dysfunction, if you do a myringotomy or a tube and you are now ventilating the middle ear pressure, that should relieve their symptoms. So be aware if a myringotomy does not relieve their symptoms, you want to be thinking about a different diagnosis. So my checklist for the eustachian tube workup. If they don't have inflammation and you don't see muscular weakness or any other pathology, what could be going wrong? They could have a bony eustachian tube lesion causing the obstruction. About 10% of our patients do have some pathology in the bony portion of the eustachian tube. And the way you can check for that is to do a CT scan at the time when their middle ear is aerated, either with a perforation or a tympanostomy tube. Patchless, very common. They have a history of autophony, popping, clicking sounds. Popping and clicking, it's more commonly patchless than it is obstructive eustachian tube dysfunction. So you look for this by excursions of the tympanic membrane with ipsilateral nasal breathing. So nose, opposite nostril closed, mouth closed, or only breathing to the one side, and you're looking with your otoscope while the patient is sitting up. And they're not doing it forcefully. Now be aware of the patients who are sniffing frequently to control their symptoms, causing tympanic membrane retraction or effusion. They can sniff so hard they can even cause an effusion or retraction pockets. They'll make you think they have an obstructive eustachian tube. but they shouldn't be sniffing if they've already got negative pressure in their middle ear. That's inappropriate sniffing. So when you see that there's negative pressure and they're sniffing frequently, think about patchless, and they're doing it to control their symptoms. Temporomandibular disorders. So it's not just TMJ, temporomandibular joint dysfunction. It's far more commonly a problem with tenderness and tight muscle spasms in the muscles of mastication. Now you can recognize this. These patients get otalgia, pain. They get sensation of fullness and fluid in their ear. They feel fluid moving, popping, clicking, many things that could make you think it's obstructive eustachian tube dysfunction. So the way to sort this out is with a bimanual exam, intra, extra oral, to examine the masseter and pterygoid space muscles. Think about a conductive hearing loss. If you have a flaccid tympanic membrane or problems with the ossicular chain, those can cause ear fullness. And the patients will often sniff or pop their ear to try to adjust how they're hearing. They may be doing frequent valsalvas, but if they're easily able to do a valsalva, that speaks against an obstructive eustachian tube disorder. Inner ear disorders, less common, superior semicircular canal dehiscence or other otic capsule dehiscences, endolymphatic hydrops, sensory neural hearing loss, can all cause some degrees of oral ear fullness. But there are many other aspects to those conditions that usually help you sort those out from a eustachian tube disorder. And migraines can cause pressure, pain in the muscles, mistaken as oral fullness. So think about that as well. Now this is an algorithm summarizing what I just went through, the differential diagnosis for oral fullness. This is something that we use every single day in the office to sort out the patients who have true obstructive eustachian tube dysfunction and patchless dysfunction. So again, if they're retracted, you see pathology on endoscopy, that's usually obstructive. But if they have a normal tympanic membrane, but they still have a consistent history of baro challenge, and you see pathology on endoscopy, just less of it, that's still obstructive eustachian tube dysfunction, just a lesser degree on that spectrum. If they have a normal tympanic membrane, but autophony, excursions of the tympanic membrane, or if you think they have that, but you can't see it on otoscopy, you can do a reflex decay mode on a tympanogram. It'll give you much better sensitivity for looking for those excursions. So that's patchless eustachian tube. And I cautioned you about the patient with the retracted tympanic membrane, negative pressure, because they're sniffing inappropriately to control their patchless symptoms. Watch out for them. They can have retraction and middle ear effusions that make you think they're obstructed when in fact they're patchless. Now, if they don't have any eustachian tube symptoms, the most common problem is the temporomandibular disorders, TMD. And then the other inner ear problems happen less frequently. Why do temporomandibular patients get so much otalgia? So this is a cross-section from Janneka's textbook. And here we see the eustachian tube. This is the medial cartilaginous lamina in the torus. This is the levator muscle in the floor. The lumen would be here. And here we see the tensor veli palatini and the anterolateral wall. And there is, right next to it, the medial pterygoid muscle and the lateral pterygoid muscles. They run along together, and any disorders with those muscles, tightness, contractions, pain, tension, can give you symptoms that the patient will think is in their ear and eustachian tube. So this is how you sort that out. We're going to reach an index finger into the mouth and palpate externally at the same time. Find the ramus of the mandible and the zygomatic arch. If you go lateral to the ramus, you can palpate the insertions of the masseter muscle, especially along its anterior border. There can be tension, looking for hypertrophy, spasms, cords, pain. And then you can run your finger medially into the pterygoid space between the maxilla and the mandible. And you can reach the lateral pterygoid muscle and temporalis muscles and a little bit of the of the medial pterygoid. So you can palpate those. Now get used to doing this with your own finger first, on yourself. Here it is in the mouth, finding the ramus, going laterally for the masseter, medially for the pterygoid fossa muscles. If you do this on yourself, you'll find that if you push a little bit too much, you can always cause some degree of discomfort, pain. So you want to find what's the right amount of pressure. And then when you do this on your patients, those who have the temporomandibular disorders, you'll find the muscles are palpably hypertrophied, soft, boggy, tender, or there may be spasms. And you just begin to reach in there and the patients will be backing away from your finger. They're so sensitive. So it's straightforward diagnosis, but unfortunately, we've not been previously taught this. And the dentists, most of them don't do this examination. It's up to us to sort this out. So there's been a recent clinical consensus statement on balloon dilation of the eustachian tube from the American Academy. This was led by Deb Toucey, and Ed McCool was the vice chair. Rich Rosenfeld was our methodologist, and I was privileged to be a part of this. So the first thing we had to do was to define obstructive eustachian tube. It's an inability to adequately equalize pressure between the middle ear and nasopharynx. The eustachian tube serves to aerate the middle ear. This is a work from Germany where subjects did not swallow or yawn for up to 2 hours, and they had a tympanogram being done frequently. So here we see increasing negative pressure. Over 1 hour, it's already down to minus 100, and by 2 hours, down to minus 170. So the middle ear gas exchange is a very active process, and we have to open our eustachian tubes to equalize that pressure several times an hour to prevent that increasing negative pressure. So if you are impaired in your ability to open your eustachian tube, there will be evidence of negative pressure. Most commonly, you can see it in the office, effusion, retraction of the tympanic membrane, type B and C tympanograms. You can measure it. But if the patient's only baro challenged, they may have a normal exam at the time, and even a normal tympanogram at the time. So you're going to be doing the eustachian tube dynamic endoscopy to look for pathology to confirm the presence of obstructive disease. Now, watch out for this. This is a fixed retraction pocket. You don't know if this patient has active eustachian tube dysfunction or not. He probably did. And the retraction of the tympanic membrane at the time, when the tympanic membrane becomes in contact with middle ear mucosa on the ossicles or under the scutum, there is a process of upregulation of inflammatory mediators that causes this inflammatory response. And it will stimulate various factors such as epithelial spreading factor and fibroblast stimulating factors. So in other words, you can get adhesion and epithelial spreading, a biological process that's now independent of the eustachian tube. So the eustachian tube may have started the process, but then it can carry on its own to become a progressive retraction pocket, even developing into a cholesteatoma, independent of what the eustachian tube is doing. This particular patient has a normal eustachian tube at this time and a type A tympanogram. So this person needs a cartilage tympanoplasty, not a balloon dilation of the eustachian tube. So watch out for fixed pockets. So the clinical consensus statement gave us indications for a balloon dilation of the eustachian tube when they failed medical or conservative measures. Chronic, more than 3 months of middle ear effusion or non-adherent atelectasis, not that small fixed retraction pocket. Type B or C tympanogram, and you see pathology on the endoscopy with that inflammatory assessment and degree of opening, the MELO assessment. Or if they've got a normal exam in your office, but they've got a strong history of flight or scuba baro challenge, you still see eustachian tube pathology, just less of it. Those are the indications. you've done that multidimensional evaluation. It's been shown, this group demonstrated that there is no one good eustachian tube test. So you have to evaluate the history, the otoscopy, audiometry, tympanometry, the nasal endoscopy, all to fully assess the function of the eustachian tube. Now, by doing that, you can usually see that there's inflammation, the most common cause, and you can try to look for the cause of the inflammation, allergic disease, rhinosinusitis, laryngopharyngeal reflux, many others. Now, beware of the patient-reported symptom scores. These are outcomes measures for before and after treatment, scoring symptoms. They are not diagnostic scores. They've been mistakenly used for that to try to assess a diagnosis of obstructive eustachian tube dysfunction. They cannot do that. They do not tell the difference between obstruction, patchless, or other causes of ear-oral fullness, such as temporomandibular disorders. So use them for what they're intended to do, to report symptoms for before and after treatment. Now, if you are going to do a balloon dilation with a balloon catheter that is small enough to be able to get into the bony eustachian tube, make sure it's calibrated so that you know it's not going to pass beyond 25 millimeters into the lumen. Otherwise, you can get into the bony eustachian tube, and this is where the internal carotid artery comes in close proximity and even can be dehiscent. So to avoid intrusion into the internal carotid artery, we're going to stay out of the bony eustachian tube. Remember, if a myringotomy or a tube does not help relieve symptoms, it is likely another diagnosis, not obstructive eustachian tube dysfunction. So why does a balloon dilation work? We think it's because it's effective in reducing inflammation. So this is a pathology study that we did in patients, taking biopsies from inside the lumen of the eustachian tube immediately before and immediately after a balloon dilation. So here we see before the dilation, thickened pseudocolumnar epithelium. It's in disarray. There's loss of cilia. There's intense lymphocytic infiltration even into the epithelium. Intense inflammation in the submucosa. Lymphoid follicles. These are adenoid-like follicles within the submucosa. Now, immediately after the dilation, the surface epithelium has been crushed and stripped off largely down to the basal layer. And clinically, we don't appreciate that degree of excoriation. So this is why it probably heals so quickly. But look at these adenoid-like follicles in the lymphocytes. They're just crushed. And yet the deeper tissues are perfectly fine. So these non-compressible balloons seem to be effective in stripping off the diseased surface epithelium, preserving the basal layer, and crushing the submucosal inflammation and lymphoid follicles. So we've had a number of specimens we've been able to get on patients weeks later, and they all look like this. Restoration of normal, healthy pseudocolumnar epithelium, restoration of the cilia, and the lymphoid follicles are gone. It's been replaced with just a thin layer of scar and some scattered lymphocytes. This is the same pathological impression that you would get after doing adenoidectomy. And so we think that's why it works, as if you had done an adenoidectomy on the adenoid-like tissue inside the lumen of the eustachian tube. So now we have a tool that can safely get us to reach that adenoid-like tissue that can become hypertrophied and cause obstructive eustachian tube dysfunction. Okay, so to look at the eustachian tube, again, this is a right side. We're looking with a 45-degree endoscope here. There's a ka. It rotated the torus well. There was a swallow. We saw the levator and then the anterolateral wall. And there's a yawn for sustained opening. Another yawn and swallow. Here it is in slow motion, levator, then tensor. That's the swallow. And then closing simultaneously. So this one's normal. There's no pathology here. You see vessels sharply, mucosa thin, there's no edema. Contrast that to this side. So right side, but now we're seeing a little more thickening here. We see two bands of redundant mucosa, They protrude into the lumen. They're not clearly compromising it, so I called it grade 2. And the lumen does open reasonably well. Here it is in slow motion. Levator, tensor, opening with a swallow. Not as good as what we saw on the normal side. So it still appeared to be adequate. I called it a grade 2, but we can see the difference between edema here, pale, thickened, as opposed to this normal band of redundant mucosa where it's much tighter. So that's how we're going to be evaluating all of these subsequent cases. Here's a 32-year-old male, tympanostomy tubes for otitis media with effusion as a child. He outgrew it, but he's always had difficulty with flights. That's that consistent Barrow challenge history. He had an upper respiratory infection last year that gave him a persistent middle ear effusion. He required a myringotomy. It relieved the effusion, but he has increasing Barrow challenge problems on flights. This is before COVID. So on exam, his tympanic membrane, left side, it's normal. Audiogram, normal. His tympanograms are normal. So here's his endoscopy. This is a left side. We see the torus here. It looks reasonably normal. There is just a little bit of inflammation here. We can see that the vessels are not quite as clear as you'd like. There's a big redundant band of mucosa here in the lumen that's projecting into the lumen. And we saw that the ability to open was not significantly compromised. He was opening reasonably well. So the main problem is this thickened band of redundant mucosa that's edematous and inflamed. So how can we manage him? He hasn't been able to improve with medical management. He could have a tympanostomy tube, but most patients don't want a tube just so they can fly. He's only bothered when he flies. He's an excellent candidate for the balloon dilation of the Eustachian tube. Now, he's got limited pathology. I only did 1 minute, and he's been able to fly fine since. Less pathology, less inflammation, less duration of inflation time. So I typically do a minute, minute and a half, or the full 2 minutes. Here's a 40-year-old female, otitis media with effusion. She had a tympanostomy tube as a child. She outgrew her symptoms on the left side, but she's had long-standing problems on the right. Also long-standing allergic rhinitis. She gets Barrow challenged on flights. She gets middle ear effusions after upper respiratory infections, and they can take days or weeks to go away. She's had 3 tympanostomy tubes on the right. They always relieve her symptoms, but the problem keeps coming back. Now she has it again, right ear fullness, hearing loss. It hasn't gone away 2 months after an upper respiratory infection. Here's her exam. She has a retracted tympanic membrane, not a fixed pocket. This is negative pressure. As you'd expect, there's some air bone gap. This is a right ear. There's a little bit of conductive hearing loss. Her tympanometry, the right side, minus 390. The left side, she has a perforation. That's why she doesn't have symptoms on the left side. All right, here's her exam. Very different from the last one. This is the right side. The thick, edematous, inflamed, torus tubarius, prominent tubal tonsil tissue here. This is lymphoid hyperplasia of adenoid-like tissue. But we see that adenoid-like tissue, cobblestones going right down into the lumen. With opening of the valve, it's compromised. Let's look in slow motion. Here goes the levator. There's the torus. There's the tensor. So there's enough edema here. It is compromising the ability to open the valve with normal swallows. So what can we do for this patient? Here, this is the adenoid. It's very much in contact with the torus, but she didn't have anterior thrusting. So she is a candidate. She's failed medical therapy for her allergic disease. She is a candidate for a tympanostomy tube again, or she could have a balloon dilation. Now, is a balloon going to be enough with all of this adenoid inflammation? I thought not. So what we did is a balloon dilation in conjunction with light cautery, just 15 watts of the tubal tonsil tissue to debulk that. and then removal of the lateral portion of the adenoid so that it no longer contacts the torus and won't interfere with opening. Now, you could also do a concurrent tympanoplasty on that left side. I do that all the time in conjunction with balloon dilation. If you do that, do the balloon first. You don't want any possible back pressure from blowing up the balloon to get up into the middle ear and disrupt your graft. So she had a 2-minute balloon dilation. Okay, here's a case. 51-year-old male, obese, obstructive sleep apnea, former smoker. He only recently quit. He's had sinusitis, but that's controlled after endoscopic sinus surgery 2 times. He's baro-challenged. Chronic middle ear effusion occurs after upper respiratory infections. He's had 2 tympanostomy tubes in the past 5 years. They do relieve his symptoms. Now he's back with ear fullness, hearing loss bilaterally, worse on the left, and they're persisting after an upper respiratory infection. He has a middle ear effusion, conductive hearing loss, negative pressure on the right, and a flat tympanogram on the left. Here's his exam, left side. There's the torus. Wow, the torus is very thick. We're not seeing cobblestones, but you don't see any of the blood vessels. Now, the adenoid here, this is the left side. Adenoid is just mildly touching the torus, doesn't seem to be a factor. There's the ka. Let's see the swallow. Swallow had a lot of anterior thrusting. Here's a yawn. He's not opening with the yawn either. It's too compromised. So let's look at slow motion. Here goes the levator. Very severe anterior thrusting. Closes the valve completely when it's supposed to be opening. So he's got cobblestoning going down, but it's very minimal. But he has very significant inflammation here. And even though the adenoid only appears to be barely touching the torus, because the torus is so thick and inflamed, he's still getting severe anterior thrusting. This is grade 4. He never opens his lumen. So he's failed medical therapy. We could do another tympanostomy tube. We could just do a balloon dilation, but that's not going to be enough for him. He's got a very thick torus. So again, we can trim the medial tissue from the torus. I never use cautery, suction cautery, on the lateral portion of the torus. That's what the balloon is for. But on the medial half, you can use the cautery and take down a lot of this bulky disease, and then trim the lateral adenoid as well. And he had nasal obstruction, so we did turbinate reduction as well with coblation. And then we did the balloon dilation for the 2 minutes. So you want to treat all of the disease that's necessary to get a good outcome. It's not just about balloon dilating the lumen of the eustachian tube. If they need sinus surgery, septoplasties, by all means, you want to do all the things that are necessary. And then you want to continue the medical care that's going to be necessary to keep them healthy. All right, this patient's an 18-year-old male. He had tympanostomy tubes at age 6. He has allergies. He's been tested positive to environmental allergens. He treats himself with nasal steroid sprays as needed. Now, we had a recent episode of middle ear effusion that lasted 2 weeks after an upper respiratory infection, and it's now resolved, but he has an upcoming flight, and he's very concerned. Does he need something done? His tympanogram looks normal today. His tympanic membrane looks normal. Audiogram, normal. Tympanograms, normal. Here is his endoscopy. Now, this is a fiber optic, pediatric fiber optic, which I use on teens and younger. Teenager, especially males, are particularly prone in our country to turning white, pale, and almost fainting. So we use the small endoscopes. All right, so here he is. This is a right side. Sorry, that was the left side. Here is the right side. There's the right torus. It's bulky, lots of cobblestoning, lymphoid hyperplasia, big adenoid in contact with the with the torus. Here's his lumen. There's a significant amount of inflammation along the lumen on the posteromedial wall, not the anterolateral wall. So what happens when he swallows? He seems to have an adequate lumen there. So let's look in slow motion. Here's the swallow. Levator, tensor. His lumen opens quite well in spite of all of this inflammation in his nasopharynx at the orifice, and even a little bit into the lumen of the eustachian tube along the posteromedial wall. But the anterolateral wall does not show any inflammation. So he has some compromise of his opening. There is inflammation in the lumen. So I called that grade 3. Clearly, no anterior thrusting, but he is functioning well, even though he's got moderate inflammation. So I'm not going to balloon dilate him. I could make him patchless, especially because he's got allergic disease. So we're not going to do anything other than measures for just flying. We recommended these vented ear plane plugs to use during the descent. He could do a nasal decongestant, have it along just in case. And I recommended, because he has allergic disease, to start consistently using his nasal steroid spray twice a day, beginning 3 days prior. It takes 3 to 5 days to build up an optimal level with your nasal steroid sprays. And I taught him how to do the modified Valsalva, which he could do in the office with me. And he's going to do that on the descent. He flew, he did fine. So just because there's robust inflammation in the nasopharynx does not mean that the eustachian tube is currently compromised. All right, here's a 64-year-old male, tympanostomy tubes, 3 times as a child, adenoidectomy. He has a chronic need to pop his left ear or sniff to try to optimize his hearing. And that's getting worse. He's now frequently popping and sniffing to optimize his hearing. He has no baro challenge history. Here's his exam. This is his left ear. Now watch what happens when he just gently blows his nose. Very thin, atrophic, flaccid tympanic membrane. And that was a swallow. He released that over pressure. So it's even adherent to his incus at this point. And he's just gently blowing at this time. So he's most likely had eustachian tube dysfunction in the past, but what's going on now is not clear. He has a conductive hearing loss, as you'd expect on that left side. He's got mild negative pressures here. He's been sniffing and popping. Here's his exam. Left side, vessels appear normal. Mucosa appears normal. There's a little redundant band of mucosa here along the floor and posteromedial wall, but that's not edematous. It's not significant. Ka was normal. Swallow opens normally. There's no inflammation here. This is a normal exam, wide open when he does a yawn. So he's grade 1. Here's his swallow. He opens. Watch his opening there in very slow motion. There's the tensor firing, completely normal. So he does not have a eustachian tube problem. He probably did in the past. At this time, he just has a flaccid, retracted tympanic membrane. It's giving him a conductive hearing loss. He's popping his ear and then sniffing, trying to adjust the pressure to optimize his hearing all the time. He's frustrated because when he pops his ear with a Valsalva easily, he can make his hearing better, but his normal eustachian tube vents the pressure. So it's not physiologically sustainable. So he thinks he has a eustachian tube problem because he can't optimize his hearing. It's about his tympanic membrane, not his eustachian tube. He needs a cartilage tympanoplasty to tighten up the drum. All right, this last case, a 48-year-old male, persistent otitis media with effusion, lifelong allergic rhinitis. He had childhood acute otitis media, recurrent, but he outgrew that. And now all of a sudden, 10 years ago, he got a bad upper respiratory infection, bilateral otitis media with effusion, and he's now had 5 tympanostomy tubes. Allergy tests are negative. He has bilaterally retracted tympanic membranes, serous effusions, and sinuses. CT shows mild mucosal thickening, not active. His exam shows retracted tympanic membranes with middle ear effusion. Here we are on the, his right ear shows bubbles, attic retraction. The left side, severely retracted, incus erosion, atelectatic. He's even starting to collect debris, beginning to get a cholesteatoma. He's got a conductive hearing loss on both sides, but look at his tympanograms. Severe negative pressure, minus 475, minus 570. Now that's a red flag. How do you get severe negative pressures in that range? We've been taught that when you get to minus 400 or more, you should develop transudates that fill the middle ear. So how do you get extreme negative pressures? That's a red flag. There's something going on here. Here is his examination by endoscopy. This is a fiber optic, right side. There's the torus. It looks normal at first glance. We're not seeing any cobblestoning. It doesn't look thick. Now we're looking into the lumen, mild band of redundant mucosa. That's all normal. It doesn't look thickened. He's got a fairly wide lumen. So we're going to take a little closer look. There's almost no bulge to the anterolateral wall. Not seeing any inflammation here. So we're going to have him do a swallow and a yawn. There's the swallow. Here's a yawn. And notice what's happening here. That light reflex that was there, it just popped. That's another yawn. And that dark space there is his valve staying open. He has a patulous eustachian tube. His valve is not closing completely. 5 years ago, he began sniffing strongly to control the autophony of his voice and breathing. But he didn't come in telling us about that. It wasn't until I saw his examination that I asked him about autophony. He said, oh yeah, I have to sniff all the time to relieve my echoing of my voice and breathing in the ear. The breathing sounds like Darth Vader in my ear. So this is how a patulous patient can fool you. Complaining of ear fullness and blockage. He's had middle ear effusions. He has severe fixed retracted tympanic membranes, possibly from earlier obstructive eustachian tube dysfunction. But now, because he's sniffing so strongly, he's retracting his tympanic membranes and making it worse. That's how we got that extreme negative pressure. He can generate the negative pressure, but before it has time to fully bring in a transudate to fill the middle ear, he aerates it with his patulous eustachian tube. So that red flag was quite accurate. So these are some results from the balloon dilation procedure, just to bring you up to date, the randomized clinical trials. There are 2 now. This first study, 323 patients, we looked at normalization of tympanograms, not just improvements. This is normalization. And so think about that in terms of your own clinical results will be better than the stats you see here. You don't have to completely normalize a tympanogram to have an asymptomatic patient. The treatment group got the balloon plus steroid nasal spray for 6 weeks after having failed maximal medical therapy. And the control group only got the 6 weeks of the nasal steroid spray. And so you can see a marked difference in the treatment group. 51.8% developed normal tympanograms versus 13.9% in the control group. The eustachian tube dysfunction questionnaire, 7 questions for eustachian tube dysfunction, obstructive dysfunction, and very similar results, 56.2 in the treatment group, 8.5 in the control group. Very strongly statistically significant results. Now, the second study, Meyer, with a different balloon device, and very similar results, 57.1 versus 10%, And the eustachian tube questionnaires, the changes in the mean scores, very significant in the treatment group, not significant in the control group. Now, systematic reviews of different case studies have all shown, including the meta-analyses, have all shown improvements in the main outcomes measures, the Valsalva, otoscopy, tympanometry, the eustachian tube scores. So the big series have all shown consistent results, despite these being quite heterogeneous in their designs. Now, studies with longer follow-ups, 2 or more years, are showing durability of the results. In this study, it was a 1-year follow-up, and the results were still holding up over time. In all of these other studies, these 3 were case studies. The Cutler study was actually this study with longer follow-up out to a mean of 29 months. And they showed durability of the outcomes in all of the studies so far that have done medium to longer term results. So the procedure does work, and we think the histology that I showed you earlier is the reason that they can get durable results if they keep their underlying medical problems under control. Allergies, reflux, sinus disease. Now, does it work in pediatrics? The Germans have done most of the work to date, and they've shown roughly 75 to 80% significant improvement, not needing tympanostomy tubes. Yankel's study, not quite as robust, but another Tischmeyer-Sudhoff study, 80% results. These are our results. In this group, 26 patients who got the balloon dilation after having failed 2 or more tympanostomy tubes prior and adenoidectomy. Now, we compared them with a matched controlled group, matched for how many tubes they had before, age, sex, and adenoidectomy. Almost all of these in both groups had prior adenoidectomies. So all of these were controlled, all of those factors. And what you see here is the history of those patients who continued to need tympanostomy tubes on this Kaplan-Meier curve, showing further need for tympanostomy tubes, as opposed to the balloon group, where far less need for subsequent tympanostomy tubes. This was strongly statistically significant. Similar study. Now, in this case, Mark Dean in Texas was the surgeon, but we compared his matched cohort controls with patients from our hospital, since we have such a large database. And you see very similar results, and his data goes out to 5 years, but very similar Kaplan-Meier curves of the treatment group versus the matched control group. So patchless eustachian tube is far more common than we thought. Now, we don't have time to go into that in detail today, but I want to leave you with the thought that this is much more common than we ever believed. Now, it's usually not looking at such a large defect as you see here. Typically, it's much more subtle defects in the lumen, and frequently they're allergic patients. You usually don't see the tympanic excursions that you see here with ipsilateral nasal breathing, but this was an extreme example of that. And again, you can have better sensitivity if you have them do the ipsilateral nasal breathing while they've got a tympanometry probe in their ear, and you're looking on the reflex decay mode. All of these are patchless eustachian tubes. Large excursions here in a flaccid TM adherent to the incus, tympanosclerosis, attic retraction. You see how it's moving. This patient's had chronic ear surgery, cartilage grafts, and yet they're patchless, despite all of that scar and retraction. This one, I don't have a video. Retractions, retraction pocket with a cholesteatoma. They are all patchless. 30% of our series of patchless patients look like this. They have evidence of chronic ear disease. They probably started with obstructive eustachian tube dysfunction. The tympanic membrane became in contact with middle ear mucosa, incus, ossicles, sputum. In upregulation of inflammatory mediators then cause propagation of the retraction pockets, even to the point of cholesteatoma. And yet, over time, their obstructive eustachian tube dysfunction became patulous. Chronic allergic disease is the most common associated comorbidity in where we see that happening. So beware, not everyone with a retraction pocket, cholesteatoma, has obstructive eustachian tube dysfunction. They can be normal, they can be patulous. So I'm commonly asked, should we be doing a balloon dilation on everyone with a cholesteatoma? Clearly, the answer is no. You've got to individually look at each eustachian tube. Cannot make an assumption. Comorbidities for patulous eustachian tube. This is our series. Weight loss was not the most common comorbidity. It was environmental allergy. We've been missing these because they typically fool us. They start out frequently with obstructive disease. They can get middle ear effusions. And at some point, they can become patulous. And we don't recognize it because the patient keeps saying they have a blocked ear. They may be sniffing strongly, retracting their tympanic membrane, even to the point of effusion, and we miss it. Patulous is far more common. It's very common. We've been taught that it's rare. It's not rare. It's extremely common, but we've been missing so many of these. Weight loss, if it's large and abrupt, certainly about a third of our patients, about a third have reflux associated. Stress and anxiety. They can do a lot of clenching. Those muscles of mastication can act as auxiliary dilators of the eustachian tube, pulling the valves partially open. So watch out for that. So the future is very bright for eustachian tube treatment. Our challenges are to do more randomized controlled trials, longer follow-up. Now that we know that the problem is mostly inflammation, we have other medical ways of treating inflammation. There's already work going on with slow-release drug delivery, targeted types of therapy. Nanoparticles could be done in the future. Anti-inflammatories could be delivered. We're seeing examples of some of these things with Trans-Tympanic Administration, Jeff Harris's group with Autonomy, that company. Dan Cohane at our children's hospital has chemical permeators that can take antibiotics through an intact eardrum to treat otitis media. Think about that for trying to avoid needing to do tubes in developing countries. Transnasal application of surfactants is being worked on by Chandra Shekhar. Steroid-eluting stents in the cartilaginous eustachian tube after doing a balloon dilation. Brian Weeks in San Diego is doing that. Doing eustachian tube surgery in place of tubes as primary therapy. I'm not there yet, but they're doing that routinely in groups in Germany. Micro machines, micro robotics. Here's a little cartoon of something of going up and doing microsurgery inside a eustachian tube. Could be possible. Patulous treatments. We need topical medical therapies that can be applied to treat the defects in the valve. Permanent injectables, they're available in the UK, but not here in the States. And the placement of commercial shims. We don't have a commercial shim that we can put into the eustachian tube, but they do in Japan, Kobayashi, and we hope to have those in the future in the States. Currently, we improvise with off-label materials. We need to know a lot more about the basic science of the pathophysiology and mechanisms of therapeutic interventions. It's coming. So in conclusion, evaluation of eustachian tube dysfunction requires a multidimensional approach. The history, the otoscopy, audiometry, tympanometry, and that dynamic nasal endoscopy exam that we spent a lot of time with today, and I hope that's been helpful to you. You want to become familiar with the anatomy of the valve. You want to see both walls. Here's the left side. There's the torus, adenoid, both walls, posteromedial wall, anterolateral wall. There's the valve. When you see that, you look for inflammation, look for other areas of inflammation. These will give you clues as to the cause of the inflammation. If you know the cause, you may have treatments you can offer. Remember about the fixed retractions that can progress independent for biological processes. independent of eustachian tube dysfunction. They are not all active eustachian tube dysfunction. Lastly, I'll just leave you with a notice that we teach our course every year, except last year, here in Boston at Harvard, our endoscopic surgery of the sinuses, eustachian tube, and the ear. We're happy to be presenting that again this year. It'll be May 3 through 5. Dr. David Kennedy will be our keynote address speaker, and it'll be all virtual. So we absolutely welcome you to join us for our course. And I hope to see you all in person once again. It's really been a true pleasure and privilege to be able to speak with you again. I have incredibly fond memories of being with you at your previous congresses, and I look forward to when I can join with you again in person. Thank you so much for this opportunity. Muchas gracias a todos. Buenas noches.
Muy bien, pues ha sido muy interesante este viaje por la trompa de Eustaquio, una estructura oculta dentro de la base del cráneo, que su parte anatómica y funcional pues lo hemos podido ver al paso del tiempo con los estudios de imagen y ahora en los extremos con la endoscopía. Desde luego, bueno, los estudios en cadáver. Entonces, vamos a iniciar con nuestra sesión de preguntas. Entonces, tenemos aquí algunas en el chat. Los que quieran hacer preguntas también lo pueden ir colocando en el chat. Y si alguien quisiera hacer una pregunta viva voz, puede levantar la mano y también lo podemos hacer de esa forma. ¿Sí nos está escuchando, doctor Po?
Sí,
Yes.
we cannot see your video.
Parece que está
No.
pasmado su internet.
Dr. Po.
No,
Let's see.
I hear you.
Okay.
Oh, but we cannot see you.
My
Perfecto,
video-
sí, es que parece que su imagen está congelada.
Mhm.
Bueno, vamos a iniciar entonces con las preguntas.
Wow.
Tenemos aquí que nos dice, en un paciente con otitis media recurrente, con derrame, con adenoides no obstructivas, que no responde a tratamiento médico y que tiene una trompa de Eustaquio cerrada, la pregunta propiamente es, ¿realiza procedimiento combinado, colocación de tubos y dilatación o inicialmente solo tubos de ventilación?
So you can hear me all right?
Yes.
Yes.
Great, thank you. If there's a full effusion, there's actually data, a randomized trial from China that would suggest that a myringotomy or a tube at the time of doing a balloon dilation may improve the results. So by releasing that negative vacuum, you can start being able to pass air through the eustachian tube earlier. So if you're going to do a balloon, but you have a full effusion, I will typically place a short-term tube, like a sub-millimeter infant tube that will stay in a few weeks to allow the fluid to drain, help the hearing more quickly. And once that tube falls out, hopefully they don't need it anymore because they have the eustachian tube balloon procedure. If they have a partial effusion, I may just do a myringotomy. If they just have negative pressure, I don't do anything to the tympanic membrane, just the balloon. Now, if the patient has never had a tube before, I will usually place a tube the first time and see how they do with it. How do they like it? And the effusion if it's an adult, the effusion often will not recur. So putting a tube in is still the first primary procedure for most of our patients. The exception are those folks who don't want a tube, like just barrow challenge. If they only want to fly and they have trouble, they don't want a tube just so they can fly. I may go straight to a balloon in those patients.
Okay, thank you so much.
Okay.
We have another question. I'm going to say in Spanish. Me pregunta Carlos Figueroa, que ha tenido usted que hacer más de una vez la dilatación de una trompa de Eustaquio. Y aparte de esa pregunta, esa es la primera. La segunda sería, ¿cuál es su procedimiento o su primera opción para una trompa patulosa, para tratarla?
So the second question, treating the patulous eustachian,
Yes.
treating the patulous eustachian tube, our first treatment is to try to understand the cause, get their allergies under control, lots of irrigations, nasal saline irrigation, so you're not drying out the mucosa, making the patulous worse with antihistamines and nasal steroid sprays. We do a lot of allergy testing, immunotherapy. So get the underlying problems under control. Get them well hydrated, off of caffeine, diuretics, get them off of the diuretics if possible. We try using saline drops or irritants. My favorite irritant is Patchoul End. It's vitamin C, ascorbic acid in a bottle. Joe DiBartolomeo distributes that from his office in California. But you could probably do the same thing with lemon juice that's diluted with saline. So placing an irritant as a drop in the nose and putting your head back in a hall pipe position, so head hanging only 15 degrees, not too far back. Place the drops, turn your head halfway to the floor. So it looks like a modified lesser hall pipe position. The patient should feel a sting radiate to their ear. That's the sign that the drop touched the eustachian tube orifice. So if they get that sting, you can often get good temporary benefit from an irritant. And if they do that on a regular basis for 2 months, they may get a lasting benefit and they don't need surgery. If they need surgery, we have procedures that we do. The most common one is I insert an angiocatheter full of bone wax into the full length of the eustachian tube and leave it in place indefinitely. I don't recall the first question.
Yes. What are your results on this plugging the eustachian tube? Are there immediate results on the improvement of the patient?
So if you're talking about doing a patulous eustachian tube, our goal is to actually try to not plug it completely, just to repair the concave defect in that anterolateral wall. So we insert usually an angiocatheter and wedge it into the isthmus. Hopefully it won't block it completely, and we'll leave it there indefinitely. Now, if their eustachian tube is plugged, and that happens about 40% of the time, at least temporarily, you can put a tube in. Hopefully when that tube falls out, they don't get an effusion again.
Thank you so much. The first question, perdón, la primera pregunta porque tenemos traductor. ¿Ha tenido que hacer más de una vez una dilatación de la trompa de Eustaquio en algún paciente?
So if you do a dilation and it doesn't work right away, you want to start thinking, is there a different problem? The problem may be in the bony eustachian tube. How do you tell? You can put a tube in, make sure there's no fluid, or if there's no fluid, you don't need the tube. Make sure there's no fluid in the middle ear. You can get a CT scan now. The CT, if it shows soft tissue density in the bony eustachian tube, now you understand that there's an additional problem. You might be able to access that from a middle ear approach. We actually do some off-label techniques probing the bony eustachian tube with illuminated guide wire, but that's in research phases. You have to be sure there's no carotid dehiscence, and it's a blind procedure. So I'm not recommending that yet, but I'm telling people that we are developing that technology. And in a very short time, that technology will be navigable. You'll be able to see that on a navigation, so you know exactly where that wire is going. So about 10% of patients will have a problem in the bony eustachian tube. That's one thing to look for. So I wouldn't repeat a balloon if that's the case. Now, if they've done well, but then they relapsed, they started not taking care of their allergies, their reflux is back out of control, their sinus disease is bad, you can get them under control again. And yes, you could do a balloon again in the future. It's just like adenoidectomy. It's not supposed to grow back. The adenoid-like tissue shouldn't grow back. But if it does, because the medical treatment wasn't sustained, you can get them back under control and balloon again.
Ok.
Thank you. Mónica.
Sí, tenemos otras preguntas aquí en YouTube y en el chat. La primera es si durante la exploración en el consultorio el paciente tiene que estar sentado o acostado al hacer la endoscopía. Y también si puede explicar qué es la valsalva modificada.
So for the office examination, the patient is sitting up. If you lie down, there's so much venous congestion, it's going to swell the eustachian tube shut. Just like a patchless eustachian tube usually goes away when you lie down. So we do the examination sitting up. If you do a balloon dilation in the office, the patients are sitting up as well. The patient's going to breathe much better, they'll be more comfortable, or there might be a slight recline, but not supine. And was there another part to that question?
Sí, que si puede explicar un poco más sobre la maniobra de valsalva modificada.
Yeah. Right, thank you. So we discourage the ordinary valsalva where patients hold their nose and they blow as hard as they can and they destroy their inner ears. We've seen people develop sudden sensory neural hearing loss and vertigo from overpressurization, and they didn't always come back to normal. So the way the scuba divers do it is the most effective and the safest way to do it. Nose and mouth closed, and you only gently blow, raising the intranasal pressure. You never do it hard, just gently blow. And while you have that pressure, the patient swallows at the same time. So it's nose and mouth closed, gently blow, swallow. So you're using the muscles of the eustachian tube to open it, not the forced air pressure. It's much more effective. I teach all the patients to do that. And if they can do that, they usually don't need a balloon dilation. Most of the patients who need a balloon are not able to do that, or it's very difficult for them.
Okay.
Doctor García Lara, ¿quiere hacer alguna pregunta?
Durante la plática, bueno, como estudios de audición, se mencionaba la timpanometría. ¿Qué tanto emplean ustedes las pruebas de función tubaria?
So we don't do any of the eustachian tube function testing. It's been much too unreliable. We don't open our eustachian tubes every time you swallow or yawn. So it's difficult on a single test like that to really assess the eustachian tube function. So we're much more reliant on the tympanometry and can they do a modified valsalva? When in doubt, I have the patients do it while I'm looking at their ear. Insufflating, looking for evidence of negative pressure. So those are that type of multifocal evaluation is much more effective than a single eustachian tube function test. The literature is very clear, as is our experience, that the eustachian tube function test that a tympanometer generates is usually not very accurate. So I don't perform it at all.
Okay.
Doctor, fíjese que fui a un congreso mexicano justo antes de que se hiciera el anuncio de que iba a haber este artículo de consenso para la dilatación de la trompa de Eustaquio, y me llamó mucho la atención que en ese entonces, no me acuerdo exactamente del doctor, pero comentaron que iba a ser obligatorio poner un tubo de ventilación y si el paciente le iba bien con el tubo de ventilación, entonces iba a ser candidato a dilatación de la trompa de Eustaquio. No sé si por ahí hubo una controversia al momento de hacer el consenso sobre el papel del tubo de ventilación antes de la cirugía o durante o después. No sé si nos puede decir algo de eso.
So the consensus statement, yes, we had lively discussions about the role of a ventilating tube.
Mm-hmm.
And the consensus was reached that a tube is not necessary prior to a balloon. So that's a very important point. Again, the patients, for instance, who have baro challenge only, they're only trouble when they fly or dive. They don't want a tube necessarily just so they can fly. So it's not required. If someone does have a tube, they should respond to it. It should help because it's going to relieve the negative pressure. So if you're not sure what's going on with a patient, by all means, you can do a tube or at least a myringotomy. If it helps them, they are likely to be a good candidate for a balloon. If they don't like the tube, if it doesn't help their symptoms, you must think about a different diagnosis. It's not obstructive eustachian tube dysfunction. So it's not necessary to do the tube, but it can be very helpful. Now, just because of the expense of balloons, it's very practical to consider doing a tube first.
Muchas gracias.
Otra pregunta de aquí del chat es, ¿con qué frecuencia realiza la dilatación en la trompa de los niños?
So the balloon procedure is not approved in US for children. It is approved in Europe. So we do it under research circumstances in our hospital, and I've done as young as age 6. The results are excellent, as you could see from our early study here. It looks like children actually may be more sensitive to the balloon than adults. Their inflammation, even though their inflammation at baseline is worse than most adults, on average, they have robust adenoids, they have a lot of inflammatory disease in their nasopharynx. But even though they have a lot of inflammation, they respond very well to the balloon. So well that we've had a few patchless patients. Fortunately, they've all gotten better. But now I don't do a full 2-minute dilation on anyone under 20.
Okay.
A minute and a half is the maximum I'll do until they're 20 years old, because they are so sensitive to the balloon.
También, doctor, creo que había
un
poco de... perdón, Mónica, si quieres adelante.
No. ¿Para los niños usa alguna longitud en especial o usa el catéter convencional?
In our earlier work, we had a series of sinus balloons of different diameters, but those are no longer available. So now I just use the standard balloon. And we're just careful to insert it gently until you reach the isthmus. And when you reach the isthmus, you feel a little stop and you don't push anymore. So the young child will have a shorter eustachian tube. More of the balloon will stick out.
Okay.
Sí, doctor, si me permite, también encontré que había un poco de controversia, no se nos pueda decir, del tratamiento médico antes de una dilatación de la trompa de Eustaquio. Creo que no consiguieron el consenso en ese sentido, ¿verdad? Creo que después sí hay un consenso, pero antes de la dilatación creo que no hay un consenso como tal, ¿verdad? ¿O sí lo hay, doctor?
So we did reach consensus that medical treatment should be tried prior to a balloon dilation if it's indicated. Mm-hmm. And the only real indication is for nasal sprays is allergic rhinitis. So nasal steroid sprays are indicated for allergic rhinitis. If you don't have allergic rhinitis as a probable cause for your eustachian tube problem, then it is not it's not recommended, and we had very good consensus on these points. So if you can find underlying pathology allergy, rhinosinusitis, reflux disease, those types of things, it's appropriate to treat them medically. And, but there is no prescribed eustachian tube generic treatment. And so the clinical consensus was arrived that it is not necessary to have a medical trial prior to a balloon if it's not indicated.
Muchas gracias.
Tenemos muchas felicitaciones para el doctor por su excelente plática. Tenemos asistentes de varios lugares de Latinoamérica que les agradecemos mucho estar con nosotros. Una pregunta dice, ¿qué tanto recomienda el uso del dispositivo llamado Otovent en pacientes pediátricos o adultos que inician con algunos síntomas de disfunción de la trompa de Eustaquio?
So we love the Otovent. The kids like the Otovent. It works. And there are good quality, high quality studies that show that they do work in children in relieving middle ear effusion. So, and in fact, that was reviewed in the clinical consensus, and it's also now in the clinical practice guidelines for otitis media. So these mechanical devices, Otovent for the kids, these battery-operated devices, ear popper, Eustachi, they do help, but the studies only have gone out to 90 days of benefit. So we don't know about long-term benefit, and we do know that compliance becomes difficult after longer periods of time. So at least for a short period of time, to try to avoid a tube, to try to avoid a balloon, by all means, you can try these devices. The Otovent in US, it's $10, cheaper than a tube.
Yes. Otra pregunta, doctor. En los casos cuando hay dolor en los músculos pterigoides o espasmos en los pterigoides, ¿cuáles son sus recomendaciones? ¿Primero una guarda oclusal, fisioterapia o Botox?
So the temporomandibular disorders is a very complicated problem. They could be grinding their teeth, they could have bite problems, they could have anxiety, they're clenching. There are so many different aspects to this, and we're not trained in managing that. So I depend on referring the patients to a dentist. We'll do the examination to make the diagnosis, and then we refer them to the appropriate dentists to examine their bite, to see if there's wear on their teeth facets that would indicate there is bruxism. Excuse me. And if they are not helped by a simple solution, such as a mouth guard, we talked about heat, warm, moist compresses, microwave packs, microwave a rice bag, massaging the muscles, extra temporal, intraoral, finding the muscles that are sore, massaging them. The behavioral modification, relaxation techniques, stress reduction. It's a whole behavioral package. So you need to get your primary doctor involved, the dentists involved. There are oral medicine specialists who really specialize in this, but they're rare. It's great if you can find one. They team up with physical therapists, they get them into exercises. And ultimately, if all of these other things are not adequate, yes, you can do things like Botox, deep ultrasound. So it's quite involved. And if you decide you have some interest in that, all of your colleagues will love you and send you those patients.
Doctor García Lara, ¿qué es alguna pregunta más? Creo que hay muchas preguntas en el Zoom. No sé si empiezo yo con alguna. Hablan mucho, doctor sobre, están preguntando sobre los ejercicios de la trompa de Eustaquio. Toynbee, Valsalva, ¿cuál es mejor? ¿Cómo dejarlos? ¿Cuándo? ¿Sería un beneficio nada más dejarlos sin mayor tratamiento quirúrgico? ¿Cuál es su experiencia con estos ejercicios?
So I do teach all of the patients the modified Valsalva, but I don't consider it an exercise because I'm not having them repeat that several times a day with sustained efforts. Mm-hmm. In Europe and in Switzerland, I observed that there's speech physical therapy, logopedy, which is trying to generate some eustachian tube exercises. We have no data on whether that works, but I can tell you what they recommend to the patients. So if you put the tip, you open your mouth halfway, put the tip of your tongue to the roof of your mouth right behind your two front teeth, and then try to swallow. You're going to feel the muscles tighten in the back of your throat. This is exercising your eustachian tube. So tip of the tongue, roof of the mouth, right behind the two front teeth, mouth half open, and try to swallow. And they have the patients do this several times a day as an exercise. Does it help?
Está interesante.
We don't know.
Y fíjese, doctor, que yo creo que aquí en México hacemos mucho, dejamos mucho al paciente hacer valsalvas, masticar chicle, tomar todo con popote, y es algo que hacemos, yo creo que de forma regular, creo que Latinoamérica, México lo hacemos muy seguido, quizás sin ninguna evidencia científica, pero yo creo que es algo ya, el status quo de hacerlo, ¿no? De dejarlo, no sé, también el doctor García Lara qué opine de eso, pero sí, yo creo que lo dejamos mucho, quizás me llama la atención de que no sea algo repetitivo que ustedes hagan. Quizá lo nuestro estamos en un error, ¿no?
Well, I don't think it's wrong. All of the things you're mentioning will help open your eustachian tube, at least intermittently. I think there's a different question. Is that actually increasing the strength of the eustachian tube muscles, which is what you're implying if you're talking about an exercise. So I don't know if it's accomplishing bulking up and strengthening the muscles, but all of those are helping to ventilate your ear. And the more negative pressure you build up, as you know, the harder it's going to be to break that lock of the vacuum. So I think all of the things you're recommending are reasonably good. It's just a question, are you actually strengthening the muscles? We don't know.
Tenemos que hacer una investigación de eso, yo creo.
Sí. Otra pregunta, doctor. Cuando habla de la remodelación de la trompa de Eustaquio, los colchonetes, usted siempre utiliza cauterio. ¿Hay alguna preferencia por el cauterio sobre el láser o simplemente porque es más accesible?
So we use the cautery if the torus tubal tonsil tissue is robust, or for lateral adenoidectomy. I use it because yes, absolutely, it's inexpensive. I avoid coblation on the torus because the plasma plume is not quite as controllable. I don't want it to get too close to the lumen of the eustachian tube. So I find the monopolar cautery is a little more precise. Now you could use radio frequency. You could use any of these cutting technologies. My colleague at Mass Eye and Ear, Ralph Metzen, he likes the microdebrider. They all work.
Okay.
En relación con el cuestionario de disfunción de trompa de Eustaquio, que salió hace unos años, ¿lo utilizan para evaluar al paciente o realmente es una herramienta solo en casos de estudios clínicos?
So there are about 3 symptom scores for eustachian tube dysfunction that are being used, and they all have the same limitations. They are symptom scores. So they're outcomes measures for before and after treatment, but they are not specific for obstructive eustachian tube dysfunction. So that's what we have to be careful about. So they're very useful in your clinical practice. How well did your patient's symptoms respond to the treatment? But you cannot use it for making a diagnosis, and it has been mistakenly used for that. If you get a high score, you must have obstructive dysfunction, you need a balloon dilation, and actually the patient had a patulous eustachian tube or a temporomandibular dysfunction or some other cause of oral fullness. And the result is, if you balloon someone who doesn't need it, you can make them patulous. So I've had to treat a number of such patients. So this was an important point in the clinical consensus statement as well, that these scores are symptom scores, they're not diagnostic questionnaires. That being said, there are a couple of groups, including ours, which are working on developing a diagnostic scale. We think it's going to work, but we're trying to validate it right now. Stay tuned.
Y muy bien, doctor. ¿Y qué tal su experiencia operando la dilatación de la trompa de Eustaquio simultáneamente con una cirugía de oído crónico? Una mastoidectomía, con timpanoplastía. ¿Cuál es su experiencia? Porque yo siempre he pensado que eso sería lo ideal, pero como usted lo comenta, pues hay muchos que tienen trompa patulosa y tenemos que tener eso en cuenta. Y justo las preguntas también de la audiencia comentan sobre las restricciones, sobre la patulosa y el oído crónico, esa relación que existe, que bueno, que estaría contraindicada una dilatación de trompa de Eustaquio.
So if you see a patient with a severe retraction, cholesteatoma, but you can see that their eustachian tube is not dysfunctional. They may have an aerated anterior middle ear, even though there's no perforation. You know there's air getting there. You look at the eustachian tube with endoscopy. It does not show significant pathology. They can do a modified Valsalva. Perhaps they have a hole, a tube, or they have a perforation. You give them drops. They taste the drops. These are all indications that the eustachian tube probably is functional and doesn't need a balloon dilation. In that case, just go ahead and do your tympanoplasty and do your mastoidectomy if indicated. Now, if they, well, so if they clearly have eustachian tube dysfunction, they've got effusion, negative pressure, you look at the endoscopy, they've got pathology, it's obstructed, then you can absolutely combine a balloon with your tympanoplasty, mastoidectomy. I do it all the time. If you're going to do them at the same time, do the balloon first, because if you blow up the balloon, but the lumen on the balloon is not open, there's a lumen to let air pressure out, so that when you blow it up, it doesn't cause back pressure to your ear. But if it were to get plugged, you're getting a false passage, or it's up against a fold of mucosa, you could cause some back pressure, and you don't want that against your newly placed tympanoplasty graft. So do the balloon first, then your tympanoplasty, but you can do them at the same time.
¿Y su experiencia con eso, con esas cirugías, cómo ha sido? ¿Cómo le ha ido? ¿Cómo lo ha visto? ¿Usted cree que es el futuro de la cirugía del oído crónico, hacer una dilatación de trompa de Eustaquio en los casos que tengan obstructivos? ¿Usted cree que sea ya lo más común que hagamos en el futuro?
Yes, absolutely. I previously was doing a balloon first, judging their eustachian tube function, and then doing the tympanoplasty, and now we do them at the same time. So I think as people become comfortable with the technique, they'll increasingly do that. And then what I predict for the future is we start treating eustachian tubes at an earlier age, and hopefully we prevent the need for eardrum reconstructions and cholesteatomas. And then going beyond that, we've learned that the balloon reduces inflammation. Well, we're going to find medications that we can deliver there that are going to reduce the inflammation even better. So eventually this is going to be medical treatment, and us surgeons will find something else to do.
Muy bien, y me encanta porque de hecho esta cirugía de la trompa de Eustaquio, y ustedes nos lo han dicho, junta a los cirujanos endoscopistas nasales, como es pues Ralph Metzon, que es un gran endoscopista nasal, y los grandes otólogos que justo convergen en esa misma zona anatómica, ¿no? Que es como tienen el curso ahorita que va a venir en mayo, creo.
Yes, that's right. So this is exactly why we teach that course the way we do. It progresses from the nose sinuses to the eustachian tube and then finishes with the ear.
Increíble. Doctor García Lara.
Muy bien, pues hemos tenido una noche muy interesante. Estos conceptos de fisiopatología, de imagen, de endoscopía, y ver la disfunción de la trompa de Eustaquio como un espectro de enfermedades es una idea que nos permite tener más claridad para el manejo de nuestros pacientes. Agradecemos mucho que hemos aprendido pues detalles y, como se dice, las perlas en el manejo de una patología. Nos llevaremos el empleo de la cámara lenta para la evaluación de la imagen endoscópica, también la evaluación llamada Milo, como le dice el doctor, y su clasificación de inflamación como parámetros más objetivos para evaluar a nuestros pacientes. Toda esta parte académica, como lo mencionamos desde un inicio, con el amplio currículum del doctor Po, es muy interesante, pero como también lo dije, más que eso agradecemos su tiempo, su amabilidad, su facilidad para compartir los conocimientos, y el horario para él es una hora más, son casi ya las 11 de la noche en el área de Boston, pero no quiero dejar pasar de decir que este colegio que está creciendo, pues hoy tuvo un récord de asistencia, casi 200 participantes en la plataforma de Zoom y más de 50 a través de YouTube. Desde luego que el ponente que tuvimos, pues es lo que ha logrado que vayamos avanzando. Agradecemos a toda la gente de Latinoamérica, de Geno Latam y de otros países que se conectaron con nosotros. Y a nombre del Colegio Mexicano de Otología, Neurología y Cirugía de Base de Cráneo, agradecemos a la doctora Celis, a la doctora Rodríguez, al doctor Benjamín García, desde luego a nuestra traductora, que nos ha hecho más agradable la noche. Y nuevamente, doctor Po, un placer, un honor para nosotros haberlo tenido esta noche, y seguramente nos encontraremos muy pronto, ojalá que sea en persona, para saludarnos más amistosamente. Muchas gracias a todos y muy buenas noches.
Thank you very much. It's been a real joy. Thank you so much, everyone, and good evening.
Queremos recordarles nuestra próxima sesión, el día 19 de febrero. Hablaremos de actualidades en autoesclerosis y con la doctora Azucena Barragán. Y el día 25 de marzo tenemos nuevamente profesor extranjero con el doctor Cernotti de Argentina sobre implantes de conducción para oído medio. Nuevamente, muchas gracias a todos. Cuídense, que estén sanos y buenas noches.
Ya me imagino que vamos a hablar con la traductora, ¿verdad, doctor? Voy a quitar la grabación.
Sí, Erika, gracias.
Gracias.